supposed to be talking about SCAPE. I am still talking about SCAPE. We are going to talk about when SCAPE is missed and how to optimize our management in SCAPE. That being said, the underlying theme is valvular heart disease. And let me just say, we're talking about acute, severe regurgitant lesions today and the management of those. We are not going to talk about the complexities of all of valvular heart disease. We don't have the time. We will talk about primarily mitral regurgitation and the management of that, which can be applied in some way to aortic regurgitation. We, again, do not have enough time to review both. However, hopefully in the future, as we have ultrasound courses, we will be able to offer you a cardiac compendium in which you can do cardiac ultrasound to kind of put things in perspective, not with your patient, but with a model, and take it to your bedside. So let's get started. I have no financial disclosures. I am no longer paying my loans off, so that's great. So I'm a nocturnist, and so we're going to start with my typical night shift. This is actually a patient of mine early in fellowship, maybe even my fellowship year. So I'm coming in early. 15 minutes is typical for me, sometimes 20 if I'm waking up on time. Coffee in hand, walking through the ambo doors, and as I come through the entrance, Baltimore Finest greets me with my first patient of the night. 50-year-old man, history of hypertension, ran out of medications, woke up short of breath. From the door, he doesn't look great. On rapid assessment, he's diaphoretic at the brim. He's obviously working to breathe, just a little. He has crackles throughout. I have no appreciable murmur. His belly is soft. His extremities are warm and well perfused. And he's able to shake his head yes or no, but obviously, given the stress, not able to speak in full sentences, or even one or two words to be honest. This is a clinical presentation we know quite well. Acute onset, sympathetic surge or activation, systemic vasoconstriction, excessive afterload, and resultant pulmonary edema. It's been known by many names. You can use any of them, but I think most commonly we use the name SCAPE. Bedside lung ultrasound is consistent with our exam, diffuse B-lines with a thin pleural interface. Left ventricle appears hyperdynamic. We do note the left atrium, when comparing it to the aorta and the right ventricular outflow tract, it is dilated. This wasn't unexpected, given his history of hypertension, so we weren't alarmed. My residents were prepared, battle ready, with the 1-2 punch, gave him nitroglycerin, and initiated BiPAP. Given that we are well familiar with SCAPE patients in our emergency department, often in a shift seeing 4 to 5 of them at a time. BiPAP settings were initiated at 12/5. Was bolused at 800 micrograms, and a drip was started at 200 micrograms. A bit more comfortable on BiPAP, and ECG was obtained. As you can see, there's ST depressions diffusely. Given the respiratory rate, his work of breathing, the tachycardia, this was not initially at all alarming for acute coronary syndrome. Likely demand. We decided we would repeat it after he was stabilized. Chest X-ray did not provide any surprises consistent with pulmonary edema, understanding that ultrasound showing B-lines may be suggestive of other processes, such as interstitial lung disease, if there's a thickened pleural interface, or even a lobar pneumonia. So obviously, we take the clinical perspective, we take the clinical pattern, but we must ensure the follow-up testing. Acute heart failure syndrome. This is a catch-all term that defines a wide spectrum of differing hemodynamic phenotypes, but overlapping pathological mechanisms. At one extreme, there's SCAPE, and at the other, cardiogenic shock. Most heart failure patients do not progress or fall quickly, however progressively, from 1 to 4. However, when there is rapid decline from warm and wet to cold and wet, you can see that mortality is staggering, 9% to 51%. So this is something we should care about, especially in the acute setting. Going back to our patient, after 30 minutes, we note that his blood pressure is improved. However, he's not particularly feeling well, nor does he look like his work of breathing has appreciably improved. Is his non-invasive settings inadequate? Is he appropriately afterload reduced? And could perhaps there be another trigger? In fact, his non-invasive settings were 12/5. However, we had up-titrating because we understand that positive pressure and the increase of positive pressure will certainly and is known to decrease your afterload as well as your preload. So his vent settings had been up-titrated to 18/12 to improve his hypoxia. With regard to afterload, his blood pressure had come down to 148. Although there is no consensus on what is the correct blood pressure, generally we think around 140 is when you'd anticipate seeing improvement. Given that he was already there, it was unlikely that he needed further afterload reduction or another antihypertensive to be included. However, you can see this with some patients. So finally, we considered, could there be another trigger? The usual suspects are lined up. Our patient was medication non-adherent because he ran out of medications. However, he shouldn't require diuresis. We know quite well that SCAPE is secondary to fluid redistribution and not necessarily volume overload. This gentleman didn't have a poor EF. He didn't have a history of chronic kidney disease or end-stage renal disease. He didn't have hepatic dysfunction with anasarca or oncotic issues, and therefore he shouldn't require diuresis and or dialysis. Moreover, he denied use of sympathomimetics such as cocaine or alcohol to suggest alcohol withdrawal, which would both warrant benzodiazepines. And finally, his ECG had been repeated after blood pressure had improved, as did the work of breathing to some extent, and there was decline in the ST depression, so not immediately warranting cath activation or discussion with the cardiologist. So this is where you're supposed to be in suspense. Nothing actually initially came to mind. This was my patient, and I was stumped. I had a lot of ECGs to go through, and I was ready to see my next patient in triage. So I said, I'll circle back. Let me give it a second to think about it. What is a great masquerader for acute heart failure syndromes? So certainly syphilis is a great masquerader, but we're talking of none other than valvular heart disease. Again, valvular heart disease is underappreciated. We will get back to syphilis later in the talk. Not only because we may be an epicenter here in Baltimore, but it actually is involved with certain valvular heart diseases. But the great masquerader that I'm speaking of is, in general, valvular heart disease. Again, underappreciated and is estimated to affect 75 million worldwide. So a staggering number there. Again, today we're going to talk about acute left-sided regurgitant lesions, which are severe. And the reason is because of their clinical impact, their narrow window to intervene before cardiovascular collapse, and their complex and challenging diagnoses. Let's start with mitral regurgitation, specifically because it is most common, followed by aortic stenosis. Mitral regurgitation occurs because of leaflet insufficiency or poor coaptation. Coaptation means closure and the appropriate closure of. So when that happens, blood is ejected instead of towards the aorta into the left atrium during systole. What occurs after that is you have a decrease in stroke volume. In addition to a decrease in stroke volume, you have an increase in afterload to the left atrium as well as pressure. You know that the left atrium, unlike the ventricle, is not prepared to handle pressures, and it does not see pressures, and that also results in pulmonary edema. Now, how does the body adapt to this? The body works quite well, and it recognizes that your stroke volume has decreased, and therefore, the heart rate increases. If you recall, cardiac output is the product of heart rate times stroke volume. So what do we do to compensate? We increase our heart rate because of the dropped stroke volume. However, we cannot do that for long. mitral valve anatomy, there are 5 components. First, the annulus, a fibrous elastic ring that separates the left atrium from the left atrium, excuse me, the left atrium to the left ventricle. The leaflets are attached to the annulus by 2 commissures, anterior lateral, posterior medial. The that attach the leaflets to the muscular trabeculated papillary muscles, again, anterior lateral, posterior medial. One having a dual blood supply and one having a single blood supply. And this is important because of an ischemic event. If you have a single blood supply, you are more prone to rupture. All right, so 5 components of the mitral valve. As you can see, this valve is quite complex with various apparatus that, if injury to any point, will result in a problem with coaptation. Primary mitral regurgitation refers to a problem with any part of this valve apparatus. And again, we talked about ischemic heart disease, specifically when you have papillary muscle rupture. This predominantly occurs at the posterior medial area because of the single blood supply we discussed. Infectious etiologies are also seen quite commonly in the emergency department, such as infectious endocarditis, when you have a vegetation that then results in an abscess formation that then goes on to have leaflet perforation in profound hemodynamic effects. From the inflammatory perspective, we think about rheumatic heart disease, connective tissue disorders. These patients are prone to having their chordae tendineae be fragile, prone to elongation, and then rupture. And then finally, we often see degenerative processes such as myxomatous disease, mitral valve prolapse, or senile calcific disease also cause the chordae tendineae to be more frail and to then, again, rupture. So this is termed, again, primary mitral regurgitation. This is different from secondary mitral regurgitation. What does that mean? That occurs because of ventricular remodeling, as you can see here. Ventricular remodeling can occur globally or in a localized fashion. With both, the papillaries are stretched and tethered, therefore restricting leaflets from closing, as you can see. Now, if it's global, it's called concentric, and if it's localized, it's called eccentric. And that mechanism, as we'll see in future echoes shortly, it has portends potentially the severity of your mitral regurgitation. So again, tethering is secondary to remodeling, and you'll hear the term utilized with secondary mitral regurgitation. The etiologies for secondary mitral regurgitation are many. Cardiomyopathies is kind of, again, a catch-all, and you see the different ones listed there. Ischemic, non-ischemic, restricted. You have this second category, dynamic left ventricular outflow tract obstruction. Everyone know what that is? Yes, kind of, all right. So what happens is you have a small left ventricular chamber because of something, let's say hypertrophic cardiomyopathy. Okay? And what happens is, as blood goes through the small chamber, there's a vacuum effect. It's called the Venturi effect, and it causes the anterior leaflet to be pushed and then to obstruct the left ventricular outflow. And so instead of blood going in systole out to the aorta, you have this secondary mitral regurgitation. And that is called, or termed, SAM, systolic anterior motion of the mitral leaflet. Okay? So this process is starred, or I should say this category is starred, because the treatment, which we'll get to in the management, is different for this one category. All other categories of mitral regurgitation are otherwise going to be treated how we'll discuss shortly, and I will contrast the two. That's why you see this. Again, coaptation just means proper leaflet touching and preventing blood from backflowing into the left atrium. On the left of your screen, you see a schematic of what proper coaptation should look like. In the middle, you see what's called billowing, and I've outlined the mitral annulus. What it means, the leaflet body is going above the annulus, and this should not happen. And then on the right of your screen, you see mitral valve prolapse, which means greater than 2 millimeters of billowing are occurring into the left atrium. On the right screen, you also see, or you may see, where the arrow is pointed, that there is poor coaptation. Those valves are not touching, and so you have mitral regurgitation. You can have mitral valve prolapse without regurgitation. You may see young women come in, you hear that mid-click murmur. You don't have to have it, or you may have mild regurgitation. So they are not synonymous. However, this schematic does show both a mitral valve prolapse as well as regurgitation, noted at the top in the atrium where you have the splash of blood. Can everyone see that? Flail leaflet, what does that mean? On the left of your screen, you have mitral valve prolapse. Again, greater than 2 millimeters of bellowing into the left atrium. When you have the leaflet tip in the left atrium, that is called flail leaflet, okay? And an extreme form of flail leaflet is when the papillary muscle ruptures, and the papillary muscle and the leaflet are free-flowing into the left atrium, okay? So that is the extreme form of flail. Now, how are you going to make this ED diagnosis? Valvular heart disease is complex and very challenging, so you have to maintain a high index of suspicion, and it has to be on your differential. If you've never seen it or never thought about it, it's not going to be there. When should it be on your mind? With every SCAPE patient, not necessarily, right? It's going to be your SCAPE patients that don't quickly improve, especially when you are addressing the issues we discussed. Is your non-invasive settings adequate? Have you ramped your expiratory pressure? Are you appropriately afterload reducing? Are you appropriately preload optimizing? And again, then you'll get to your triggers, in which case you may bring out your color Doppler, which we're going to discuss shortly. POCUS here is meant to identify severe acute regurgitant lesions because we don't have the luxury, as we saw with the mortality drop, to wait. I work at nighttime always, so there is no ability for me to do an in-house echo with a sonographer, although I would love it. I can call my consultants down, and we will be discussing early consultation for these patients. These are the patients that when you have a question, and if you are uncomfortable doing that ultrasound, you should be calling your cardiologist or your cardiac surgeon to have the conversation sooner than later because your patient life depends on it. Before we get into specifics of 2D, which you guys already, I'm sure many of you do all the time, day in and day out on your shifts, let's talk about how to optimize your ultrasound images. The first thing is to make sure you are minimizing your depth, right? You don't want to waste any of the space. You need to kind of have in front of you the business of the matter. So here it's the valve. You need to narrow your sector. And what does that do? I know we don't like to talk physics, certainly not me. I see Dr. Earl looking at me, and he's our ultrasound director. And so what that means to me is it makes my picture look pretty, right? It gives me a good temporal relationship, if I'm not mistaken, is how they term it. And so it means that the frame rate is high enough. And so you see that this ultrasound is a very narrow view of, afraid with this tech that sucks, but a narrow view here of the ultrasound sector. Something works. All right, and then you're going to increase your gain to make sure you have a pretty picture. So make sure your pictures are crisp before you go on to look at your apparatus. So the first thing is, we'll get to chambers second because you guys are pretty good at looking at chambers. The leaflets. You see here we've listed all the things we just discussed. Your annulus, the coaptation of the leaflets themselves, the tethering that comes from remodeling, and then the morphology. Are they calcified? Are they thick? Are they calcific? Okay? So what do we look for? Is the annulus dilated? That's the first sign. It shouldn't be widened, and that typically comes from either chronic AFib that remodels the left atrium itself and widens it, or from the bottom in the ventricle where you have that tethering and remodeling that widens the annulus and restricts the leaflet. As far as coaptation, we already discussed the things you can see: billowing, mitral valve prolapse, a flail or an extreme flail, even sometimes regurgitation, vegetation, or calcification. So those are the things you should be looking for on the leaflet specifically. With regard to chamber size, as we said, because these patients have acute etiology, this is an acute etiology, you're not going to see many changes in the chambers. You may see some mild dilation, more so in the atrium that you will with the ventricle. However, if they have underlying, let's say again, hypertensive heart disease, you may see dilation both in the ventricle and the atrium. So nothing different than what you're typically associated or what you typically are looking at. What is the one thing that I would like you to remember? These patients are going to be very hyperdynamic. And hyperdynamic is not synonymous as tachycardic, right? Hyperdynamic means that you have the left ventricle almost closing on itself. The valve hitting the leaflet very aggressively is different than a heart rate that's fast. And the reason it's important is because my residents sometimes, and even me as in early training, thought that's a great sign. I see some shakes of the head no. Is it a great sign? No. One of my residents want to tell me why? It's working too hard? Definitely. Often it's a surrogate that you may be preload down, right? And here you're not necessarily preload down, but preload shifted, because the blood is going back into the lungs, and so it's not going back to the heart, to the right side of the heart, and so your preload may seemingly be down, right? Although in this case, again, you're not down. So it is a bad prognostic sign, not only in valvular heart disease, but even in sepsis. They've showed that a hyperdynamic EF, meaning greater than 70%, is just as bad as a EF of less than 10%. Okay? They say 10 to 25%, depending on the literature. So hyperdynamic EF, really poor EF, both very bad. That being said, I would rather have a hyperdynamic EF with an acute valvular lesion than a normal EF, because that means you've caught them too late and they will spiral, so be prepared. Both of these, again, are bad. All right, on to color flow Doppler. This is kind of the meat and potatoes of what I want you to take home with you. Do not be scared of this. No, actually, no, be scared of this. I'm still scared of this. It is very complex and not in our purview for the most part. However, when your patient is suffering with the potential of an acute severe lesion, you should know you can push this button and you should get some information. Even if you are unsure, better you be unsure than your patient be dead, okay? And you're already using your ultrasounds to assess patients, whether a rush exam, looking at joints for effusions, blocks. So you have the ultrasound, utilize it. There's a color button. We're going to kind of go through some specifics. Don't worry, we're not going to go through too much physics. So the first thing that is, and to be honest, color flow Doppler is the basis in which we identify regurgitant lesions, right? So it's essential. The color map is circled, and what is this? It defines the color assignments to direction of flow. And by convention, we know the BART mnemonic, or some of you have heard of the BART mnemonic. Is that, can I see raise a hand? Who's heard of it? Who hasn't? Okay. So I see some people. So again, the color map is just assigning and defining, basically when you have your transducer, which way the flow denotes what color. And so by convention, blue is away and red is toward. The Nyquist limit is the upper limit of velocity of blood flow that the ultrasound machine can display. And aliasing occurs above the Nyquist limit. And so it is represented, and that means, again, the ultrasound machine cannot display it accurately. It's going to be displayed, it's just not accurate, the velocity, because the velocity is so high, by the way. And that is called aliasing, and it's displayed by a multitude of colors, blue, yellow, red, together. And we will see examples of it. The color box, when we have a color box, make sure you can change the size of it, and you need to make sure that it includes your valve apparatus as well as the entire receiving chamber, because as we'll talk about shortly, when you look at the body of the regurgitant jet, it does matter how it's directed, and to ensure that it's fully accounted for in your measurements. There are 3 parts of severity that we're going to focus on, and I should say 3 parameters of the regurgitant jet that we're going to focus on. And I would not commit to memorize the numbers that we'll talk about shortly. This is something that you just need to know how to identify, and then you're going to look up the numbers, right? This is not meant, you don't want to waste valuable brain space, and as I get older, I realize I'm probably remembering less and less. So the first part is the flow convergence zone, okay? The flow convergence zone. And I'm going to move on. Hopefully you can see that the flow convergence zone where I'm pointing to on the left of the screen is similar to the one at the right of the screen before the valve, where the annulus is, and that is called the valve orifice. So the flow convergence zone. Then second, you have your vena contracta, and third, you have your regurgitant jet body, okay? So this is called, when it's in the receiving chamber, it's called the body. Let's go through each of these. Flow convergence, what does that mean? That is when the intensity of velocity increases before it goes through the regurgitant orifice. And I would liken this to you being in the bathtub and you opening the drain and everything kind of circles quickly around that drain. So the intensity is increasing before it goes down. Does that make sense? All right. So how do you measure that? It's going to be as you see here in the apical forechamber, and you're going to measure the radius from the first aliasing, which is the first color change that you see in red, to the vena contracta orifice. Okay, and that measurement, that radius, is the flow convergence zone. Questions about that? Make sure when you're doing this, obviously, as you can see here, you're going to be in a zoom. You need to make sure you're zooming in, and you, again, these patients are quite tachycardic, so how are you going to do this? Just as you would in a code, you're not going to put your probe on while, during cardiac arrest trying to identify different things. You're supposed to find the best image, clip, then come off, then cine scroll, and you're looking through. So that's what you're doing here. Make sense? These patients and these jets are going to be difficult. I mean, sometimes they're obvious and frank, but with the tachycardia, it can be very difficult. So you need to make sure that you're using your freeze, zoom, cine scroll to find these things out and to make these measurements and to analyze these things. The vena contracta is the narrowest point of the jet orifice, okay? And this is measured a bit differently. Typically, when we do color Doppler, the angle of intonation, as they call it, which basically means your position of your transducer needs to be parallel to blood flow. However, here, when you're getting the vena contracta, you're perpendicular, okay? So the parasternal long view here, zoomed in on the mitral valve, and you're seeing the vena contracta, the narrowest point where the velocity is the highest, and you need to measure this circumference. And finally, the jet direction and body. So the first thing to know, again, is the jet direction can represent how severe the lesion is. So there is something called concentric and eccentric, right? As we talked about when you saw the tethering and how the tethering force can affect papillary changes. So if it is concentric, it often overestimates the regurgitant flow. And if it's eccentric, it underestimates it. However, eccentric jets are more suggestive of a severe lesion. And we'll talk about different ways that you can see that. One of them is aliasing. And so you see a little bit of aliasing here. Now, in addition to just looking at the body of the jet and which way it goes, the direction, you can calculate the area. And that area is highlighted there. So the area of the jet itself, I did re-highlight it over the actual initial ultrasound image because it's not as clear. But the jet body area, and your ultrasound should have, if you have a cardiac package, the ability to do this, jet area, and then the area of the entire left atrium, and a ratio of them is the number you want to. Let's look at some examples. Obviously here, even before looking at color, you notice that the left ventricle is hugely dilated, right? And so again, this dilation is going to cause this tethering. And because it's global dilation, the tethering is likely going to be concentric. And you see this regurgitant jet is in the middle. And how would you quantify it? Just from eyeball alone. Okay. So what are we looking for with the regurgitant jet? As we said, blue is away, and the receiving chamber is receiving blue as the atrium. So that jet is actually quite mild. So although you see all the different colors, this is the blue color that you're focusing on. It doesn't hit the posterior wall of the atrium. It doesn't come far into the atrium. And there is no aliasing. The other colors are uniform that are going through. All right, let's go on to the next one. certainly you can see the valvular abnormality itself, okay? And at first glance, when you start to look at these images more, this may look like it's more severe. However, this is quantified as moderate. And again, this goes to show that if you have a concentric jet, you can overestimate. However, if you have eccentric jets that may not look as good, or I should say not as good, but are not in the middle, they can underestimate it. So this was actually overestimated as severe, but quantified as moderate. And finally, severe. This is an eccentric jet with a lot of aliasing. So you see all those colors mixed in almost like a rainbow. It hugs the wall. This has a name. If you hear the Kawanda effect, it means it takes the cavity shape. Okay. Sometimes you can even see swirling, and it's not only is it hitting the posterior wall of the left atrium, but also if it is filling up more than 50% of the atrium itself, that is pretty significant. All right. Again, flow convergence, vena contracta, and jet area. These numbers that I'm going to show you, they should not be memorized, but understanding that these are the areas or the parameters that you can look for when grading the severity. Again, only in severe lesions. And you need, in order to grade it as severe, you should have 4 different criteria met. And that is also to include 2D, which we discussed. If you have a clear coaptation problem, tethering problem, annular problem, leaflet problem, and again, I wouldn't remember those by memory. You're just going to look up the severity calculator, and it will tell you, for instance, flail, severe leaflet, severe chordae. There are different criteria in which the leaflet in 2D, just visual analysis, should meet 1 criteria, and then any one of these. So if you have 4 criteria or greater than 4 criteria, then it is positive for severe MR. So a large flow zone, a width of greater than 0.7, and a jet area of greater than 50%. We talked about or touched on these other things as well. Going back to our patient. So this was actually our patient. As you can see here, although he was hyperdynamic on the initial cardiac ultrasound, especially if you're quickly rushing in our busy EDs, we didn't notice that there is a posterior valve abnormality. Can you guys see it? Yeah, there's a flail there. So flail leaflet. And then I'll have a zoomed in image and then color on it. So there you see the flail. The leaflet tip is in the left atrium. And as you can see, there's significant mitral regurgitation. So flail leaflet means the tip is in the atrium, significant regurgitation with color. So we're talking about warm and wet patients. Obviously, again, these patients can occur anywhere on the acute heart failure spectrum, anywhere from warm and wet to cardiogenic shock. So management is going to depend on where you catch them in that stream. Hopefully you catch them early enough. The management here is the same as you would do for SCAPE. Afterload reduction, afterload reduction, afterload reduction. And what are you going to utilize? The same things you use, non-invasive and vasodilation, which is why we reviewed. Make sure your non-invasive is appropriately set and your sets are being ramped to optimize your expiratory phase or expiratory pressure, I should say. Vasodilators here are slightly different. Nitroglycerin is fine if that's all you have. However, agents such as nicardipine or clofidipine should also be considered because obviously this is not just pulmonary edema. This is a different variant, so you want more titratable medications. And certainly nitroglycerin we know can have adverse reactions, especially if you're not screening people for things like phosphodiesterase inhibitors. So calcium channel blockers are fine here. As far as preload optimization, diuresis is the way to go. Loading conditions is very important in these patients. And so as long as hemodynamics are optimized, and again, they're not hypotensive, if they are normotensive, diuresis is definitely the way to go. And in these patients, because the afterload is high, you're trying to reduce it with these therapies, remember that the map that you're looking for is going to be slightly lower than you'd want in your normal run-of-the-mill patient, you know, aiming for 65. So there is no consensus on the appropriate map, but just as you would lean towards a lower map, for instance, in aortic regurgitation patients, you want them to be not hypotensive, but relatively low, similarly here, because afterload is a bad thing. And finally, chronotropy, we talked about this. the fast heart rate that they're having, that is compensatory. And if you stop that by giving beta blockers, for instance, you can have catastrophic decline because it's compensatory and it is what is keeping your patient alive. Similarly, if you have a patient with AFib that comes in septic, right? You want to identify that they're septic, control for that, and often the heart rate will come down to lenient heart rate control. That being said, if the patient is significantly tachycardic, of course, right, 170s, 180s, you should address those. And it's unlikely that they're going to have a sinus tachycardia in that rate. Those patients may have atrial fibrillation, and the most important thing there is to ensure that there's no concomitant other valvular process, a mixed process like aortic stenosis, which would require defibrillation. Inotropy, if the person does drop blood pressure, what do you want to do here? Well, you're between a hard and a rock place because all of these medications, many of them are going to increase your afterload, right? And so I personally like epinephrine in these patients, and that's what I used in the patient that we showed you that I had from early attendinghood. And so epinephrine at low cardiac dosing is going to have minimal effects on afterload and give you a little bit of inotropy, so forward flow. That being said, the drug that rules them all, and I think they must be paying for everything because norepinephrine seems to be the way to go with everything, is also listed there. So again, you have more alpha with norepinephrine, and that's going to increase your afterload. So in my warm and wet severe mitral regurgitation that's acute, I'm probably going to pull epinephrine before norepi because I don't want that alpha. Mechanical support, what can you do? There's really minimal options because as you know, ECMO, Impella, all of these things increase your afterload. And you can, if they're in extremis, go that route. However, you're going to have to do more than one of those things in order to decrease the afterload. Often they'll use ECMO with Impella, right, or a transeptal approach. The best way to go is an intra-aortic balloon pump in these patients because you are decreasing afterload with that. And so the patient's in extremis, and if they can't make it to the OR, often they're going to get a balloon pump before they go to stabilize them. And then what are the consultants going to do? Your consultants are going to do what's called a transcatheter mitral valve repair. There are many types of these. I think the way to go right now is an edge-to-edge repair, and you may see something called the Mitra clip utilized. It has many studies utilizing it, compared it to annuloplasty. The third repair method is escaping me. However, all to say is these are transcatheter approaches, so as minimally invasive as you can be before actually repairing the valve. And then later, they'll determine if there needs to be a more definitive surgery. Moving on to aortic regurgitation, we're not going to spend a lot of time here. I just want to review the pathology that we often think about. Of course, trauma. Many of these patients don't make it to us when they do have trauma and they have catastrophic collapse. However, dissection, of course, we think of hypertensive disease, but we also think of people that have used sympathomimetics, people with connective tissue disorders. Infection comes up here again, circling back to syphilis, aortitis. Syphilis is still the great masquerader. Iatrogenic issues and congenital issues are less likely, but with congenital fenestrated cusp. But the same tenets of management apply here. You're going to look for valvular abnormality. You're going to look for a large flow convergence. You're going to look for a vena contracta, and you're going to look at the jet area. And you're going to look up the numbers later, right? You just need to utilize the Doppler to get your pictures, and then you're going to see how do those pictures compare. And when there's concern, you're going to get an early consultation. How does the management actually different? Again, preload, vasodilation is the way to go, as we know. Afterload is vasodilation. Preload is diuresis when hemodynamically stable and optimization, which is a bit harder with aortic regurgitation. And chronotropy, the mantra is control the heart rate before blood pressure, correct? You guys all taught that? Is that still being taught? I'm not that old. Okay, so esmolol drip, right? These patients can decompensate very quickly for the same reason as with mitral regurgitation. So have caution, have caution. You don't want to crank that beta blocker. And in fact, sometimes I may do a small test and see before I'm putting my drip on, so just be careful. Inotropy, same thing. Now here, what is the support device you can use? Really nothing, right? You need to go to surgery. Because everything, I mean, again, the balloon pump would not be utilized here, and ECMO and the Impella are both going to increase your All right. I think I'm a few minutes over, but I think I get to take them back because of all the tech difficulties. Acute severe regurgitant valvular heart disease. It is a masquerader of an acute heart failure symptom. Don't forget about it. The SCAPE requires you to think about triggers. Even if a patient is improving, if you don't start to think about these things when you need to think about them, they will not be on your differential. So please don't forget it. POCUS is vital. You are already utilizing it. You can do this, and it will shift your diagnostic momentum, and it will save lives. So look for the things we discussed. Is the patient hyperdynamic? That is not a good prognostic sign. Are there any abnormalities in the valvular apparatus? Slow down and take a look. Add color flow when necessary. Critical valve disease is going to fail medical therapy, inevitably. And so you have a very narrow window if you happen to catch these patients before catastrophic collapse. They are afterload sensitive, so make sure you have calcium channel blockers, nitroglycerin, whatever your agent of choice is, nitroprusside, whatever you have. Aim for a lower MAP. There again is no goal. I tend to aim for about 55, maybe 60, but no higher than 60. If they are volume overloaded, as long as my hemodynamics can allow for it, I'm going to diurese them. I want to decrease the loading pressure. Sinus tachycardia is good. Mechanical support options are minimal. Get your consultants involved early, and when in doubt, still get them involved. It was wonderful talking to you.